All right, welcome to the Heal with Ease community. This is just going to be a short lunch and learn on MRIs and imaging and kind of their relationship to symptoms. And I know that we've covered this a little bit before, but I'm going to start with just a little bit of my own story. I know many of you know I broke my foot last summer. And so this was my fracture at the day that I did it, okay? So this is the outside of my left foot, the fifth metatarsal long bone. And this is the same angle of the fracture about 4 months later. So this was the end of June and this was the end of October, after I had already been playing tennis pain-free for about 4 or 5 weeks. So you can see that even though the bone doesn't really look like it's healed from this particular angle, I was incredibly functional and completely pain-free. And it does look more healed from other angles, but I thought it was really interesting that it would be very easy to look at this and get stuck in a story of, oh my gosh, that must hurt. Even my husband looked at it and was like, I can't believe your foot doesn't hurt. But I was completely pain-free. And it, and so imaging doesn't tell the whole story. And often it's not the greatest way to create a baseline assessment. And part of that, I've seen some research about how back pain patients that know their MRI results have higher levels of pain than those that don't know their MRI results. So as soon as you have an imaging or an image of the area, and if it doesn't look great, it's very easy to take that on as part of your personal identity. This is also my foot the day of my foot fracture, but which you can kind of see through in this area. But what I wanted to show you here is this lovely bone spur on my heel. And I have a long history of plantar fasciitis, so it makes sense that I might have a bone spur there. But I have not had plantar fasciitis symptoms in years. And I'm back to running. I can do anything that I want to and wear any shoes that I want to. And I didn't need to have the bone spur removed or have an injection or anything like that. But I thought I sort of giggled when I saw the bone spur and how big it was, and was actually kind of glad that I was able to manage it in other ways. And at the end of the day, what actually made it go away for me was taking a tincture of herbs for hormones. And I had not even considered that my perimenopausal state was responsible for my plantar fasciitis. But I know that high school and college age girls are more likely to rupture their ACLs during certain phases of their menstrual cycle, because every month your body's trying to make you go through a phase where the ligaments are made more lax. And and that just, I think, gets a little wonkier as you get closer to menopause. But stabilizing my hormonal system did wonders for my plantar fasciitis. And in a very short order, like in about 3 days, a year's worth of struggling with it was just gone, which was absolutely amazing. So just to give you kind of the big picture on this, even on MRI, if you have a herniated disc that's in contact with the nerve root where it looks like there's actual visible impingement, it is a weak predictor of low back pain. So that does not tell the story. Psychosocial issues like depression, fear of movement, and fear avoidance beliefs tell the story much more clearly. And when you look at both acute and chronic low back pain, imaging does not typically provide any useful information. Unless you're suspicious of something like a tumor or other kind of cancer, that there's something going on that's not just a mechanical issue. Imaging does not typically give useful information. I'll throw fractures into that. Imaging is obviously good for fractures at some level, but you still have to have, I think with MRIs or with x-rays, you have to have at least a 30% change in bone mass for it to even be picked up on MRI. So things like bone bruises, which there's a ton of literature about, do not get picked up on an MRI. And those are like micro fractures, but they're definitely a thing. And probably one of the ways that they most commonly show up is if you slip and fall and kind of feel like you bruise your tailbone and you have a hard time sitting for 6 months or a year, that's a great example of a bone bruise, but they happen in many other ways too. I just pasted, you can find this online, and if you want it, just send me an email and I'll send it to you. But this is the fear avoidance beliefs questionnaire, so you can kind of look at that, and it gives what they found as this was developed, that there are 2 scales in here. One is fear or avoidance beliefs about work, and one is about physical activity, and those each have, so those get scored separately in it. But so when you believe that you can't do your normal work without your pain, and that the pain evokes the real fearful response about what your ability to move, that is a huge issue with in back pain, much more than imaging or x-rays are. And so this is the scoring. And so you can, if you go back to the one above, you score these questions for work and these questions for physical activity. And if you want to go through that and kind of see how you feel, you can. And so this one is the FABQW is for work, and FABQPA is physical activity. So if you want to go do that and test yourself, you can do that. And if you want me to email you the PDF of the test, I can do that as well. It is also available online. The placebo effect is really big with, when you look at interventions. And one of the things with imaging is if the imaging isn't going to change your intervention, then there's really not reason to do the imaging. So this is a summary of a review that took all the known sham surgery studies. And sham surgery is when, instead of, like, if they're going to do a knee surgery, instead of actually doing the knee surgery, they put you under anesthesia and they do the whole routine and make all the same noises and everything that would be made going into surgery, but they just make the incision and then stitch you back up, and they don't actually do the surgery. And so in a comprehensive review, sham surgery was beneficial in 74% of trials, and in half of them it was beneficial to the same degree as the actual procedure. And in some cases it was found to be more beneficial than the actual procedure. So sham surgery across a lot of the literature, and this goes from back surgeries to knee surgeries to shoulder surgeries, gets very often equally better or even more better than people than the actual surgical, those that underwent the actual surgical technique. So your belief, the amount of power that you give the intervention is directly related to your outcome. If you really believe that this is going to heal you, then you get really great results. And it really is a big testament to the body's ability to heal itself. And, and also I'm sure some of the underlying psychosocial factors as well. Lissa Rankin has a really great book out called Mind Over Medicine that talks extensively about this and how medicine really needs to be leveraging the placebo effect rather than dismissing it. One of my 2 favorite stories out of her book are that this is of a woman, and it was found that after some extended period of time, because she's a physician, she got kind of the backdoor story. I don't think this was anything that ever made the news or came out, but a radiation machine had not been working for some period of time. But this woman who had gone through her 6 weeks of radiation with a machine that wasn't emitting any radiation had been completely cured. And how do you explain that? That was certainly her giving that intervention a lot of power. And, she was very optimistic about it. And, that was at least the backdoor conversations from the doctors, because certainly the hospital was quite horrified to find out that the machine wasn't working when they thought it was. The other really interesting study that she profiles in the book is giving healthy young college-age students, they injected them with normal saline, just water, and told them it was chemotherapy. And 20% of them had hair loss, even though there was no actual chemotherapy, but they believed it was chemotherapy. So and it was a relatively small group, maybe 20 or 30 subjects, but but they had a few of them that were reporting hair loss from the fear of it being a chemotherapeutic agent. And so, they certainly gave that the power to cause their hair loss. And so our mindset around our injuries and our conditions is just incredibly important. And, going back to my foot fracture, I'll say that I really, other than the initial impact, had no pain in my entire recovery. And when I was at the urgent care doctor, the doctor there looked at me and said, "Melanie, you're the happiest person with a foot fracture I've ever seen." And I was like, "Oh, I should be." And I told her a little bit about what I do with the vagus nerve, even, with mind body medicine. I was like, I should be the happiest person with the foot fracture. So that made me feel good. And even when they asked me my pain scale, I was probably a 3 or 4, but I think when I asked them initially, I just amped it up a little bit. I said it was something like I told them it was maybe an 8 at the worst, and I was certainly fearful of knocking it, anything, but because I know the game they were playing, I didn't really want to sit there and say that that I had absolutely no pain. But I told them, I said, that it really wasn't. So as long as I wasn't moving it, it was fine. So what does shape the story? So heavy physical work, heavy or frequent manual operations, repeated rotation of the trunk, whole body vibration, and prolonged sitting are positively associated with low back pain. So there are absolutely particular movements that give you, that contribute to back pain. So back pain is much more about your mental state and how you're moving, or what particular movements you're doing, than it is about whatever your spine looks like on X-ray. And the other studies I can quote from a conference I went to a few years ago, the director at the University of Delaware's PT program does a lot of geriatric related research, and he's been part of epidemiological studies, with like 30,000 people each. So, and he said that basically in people over 60 with spinal arthritis, half of them have pain and half of them don't have pain, even when you divide them up for equal severity. So you can have a crappy spine and not have pain. And that's very consistent with all the other research that's out there, including the ones where they can just pull people off the street and find they have herniated discs and impinged nerve roots and things like that, but are completely asymptomatic. Part of the difference in that, I believe, is in shock absorption. And that's really part of what I look at when I see somebody in person with their my vagus nerve system, is because I'm evaluating from their big toes all the way up to the top of their head. And by the time somebody comes to me with back pain, they're not moving correctly at their big toe, their ankle, their knee, their hip. And they're not moving well above it either, like at their diaphragm, through their chest and shoulder areas, and certainly at the base of their skull, and sometimes into their neck as well. And that's a little more consistent with with finding that performance actually predicts decline, institutionalization, and longevity. And maybe we'll do a session around this, because some of this is kind of fun, like how many times you can go sit to stand in 30 seconds, or how many if you can get to calf raises with to 25 calf raises at a particular metronome beat is a good standardized test. Your ability to go from sitting on the floor to standing without using your hands predicts longevity, as does your grip strength predicts your health 25 years into the future, which I think is really fascinating. The research around grip strength is absolutely amazing. It predicts virility in young Swedish men. There's a lot of, but grip strength is a very, very powerful predictor of health. And I had a discussion with a cardiologist some years ago, and I don't know if he actually implemented it, but I was telling him about some of that research. And because at the hospital, they really wanted to know when people were, they wanted a quick, the nursing to be able, they needed a particular discharge assessment measure. And I told them that, that it's something that was maybe it would predict being readmitted, because the hospitals are really getting punished by the insurance companies if somebody gets discharged home and then they come back into the hospital. And ideally, you want everybody to get better and stay home and not need to come back anyway. But I really thought that grip strength would be a good thing to throw in the discharge routine, because it would be, I think a stronger grip strength would be less likely to get readmitted. And he said that in his heart attack patients, he always knew somebody was going to get better when they were hungry, angry, and horny. Like if they were in the ICU and they wanted to eat, they were angry that they were there, and they wanted to have sex, he knew that they were going to be just fine recovering from their heart attack. So I thought that was interesting insight as well. And that's all I have for you guys today. And let me know if you're interested in doing something more on those standardized tests, because I can pull together, especially some of the ones that might be more appropriate for the age range that's here. But it's good to know just there's lots of standardized tests out there that do predict your injury future and your health future, and it can be empowering at least to know about them. Even if you can't do some of them to yourselves, you can go ask the physical therapist near you or your doctor, and maybe find somebody who can take you through that kind of an assessment. I will see you all next time. Thank you so much.